Good evening, ladies and gentlemen. My name is George Cooper, and I'm president of King's, and it's my honor on behalf of the university to welcome you to this lecture, the Saul Green Memorial Lecture. King's is deeply honored by having been invited to host this lecture series, now a permanent fixture of the intellectual landscape here at King's. So thank you so much to Roselle Green and the Green family, all the Green family, and to Shaar Shalom Synagogue, with whom we sponsor this lecture in association. The topic tonight is empathy. In our professional worlds, professional lives, Saul and Leo Green were the epitome of empathy in their practice of medicine here in Halifax for so many years. I'm part of the other tribe of professionals, lawyers, and knew the other side of the Green family, Nate and Al, actually better than I knew Saul and Leo. They were wonderful models to us in our legal profession, both of them. I will tell you a little story about Nate, if I may, and the subject of empathy. I well remember a case in his court in which, briefly stated, the facts were that a young man about 19 years of age was found by the police at about 3:17 in the morning, emerging from that store, that grocery store, right at the corner of the Purcell's Cove Road and the Herring Cove Road as you go around the Rotary and out there, through a broken window, carrying in his arms a whole bunch of cigarette cartons. And the police said, well, my, what are you doing here at this time with a broken window behind you and huge cartons of cigarettes in your arms? And his explanation, which the police did not accept, but Nate Green did, was that as he was walking home a little earlier that evening, he happened to notice that the window was broken, and he happened to notice that the interior of the store was in considerable disarray, and he thought that as a favor to the person who, in fact, owned the store, that he would do a little cleaning up just before morning came round. And so that was his story, and Nate said, well, I'll buy that, and that was empathy, legal style in Nova Scotia. Nate Green, one of the greats. And Al, my heavens, I see Al there. He has had a marvelous career, both as a lawyer and then later with the Public Utilities Board. So my acquaintance, as I say, with the Green family is more with the legal side than with the medical side, but I do know that the whole family exudes empathy in the professions. And so what a great thing it is, what a great privilege it is for all of us tonight to have Dr. Brian Goldman here with us to talk about empathy in the medical profession. And I'm going to turn this over in just a moment to Seth Bloom, Dr. Seth Bloom, representing the Shaar Shalom Synagogue, to introduce Brian. But let me just say to Brian and to others that, in fact, I just arrived back in Halifax not an hour ago from attending a CBC board meeting, and I have the cufflinks here to prove it. There they are. And when I said to my fellow directors earlier today that I was coming tonight to hear a lecture by Brian Goldman, there was envy that you could cut with a knife right around the boardroom table. a wonderful contributor to the CBC and to the profession. So now, Dr. Seth Bloom, who will introduce Dr. Brian Goldman. Seth.
Good evening. We think of medicine and law as separate, but sometimes they intermesh. And if or when that happens to me, I hope I can trust in your empathy. If you were to go to any urban city emergency room anywhere in Canada tonight, what you likely would see would be a lot of people waiting for care. Waiting for care, you'd see probably sick people lying on stretchers, waiting for care. You likely would see busy professionals hustling. You might describe their pace as a bit frenetic. And the people who go to such emergency rooms, by nature of being sick, injured, or concerned, are vulnerable. And it's a never-ending revolving door of people entering the healthcare system. How do healthcare providers, doctors, nurses, support workers, maintain empathy? How can they continue to have dignity or to respect the dignity of the patients that are entrusted into our care? Well, tonight, Dr. Brian Goldman is going to talk about that, and he's in an excellent position to illuminate us. He's a physician, graduate of the University of Toronto Medical School, and an emergency room physician at Mount Sinai Hospital in Toronto, as well as a career in broadcasting. As you know, he's the host of CBC's White Coat, Black Art, and he's the author of a book, The Night Shift, Real Life in the Heart of the ER. Dr. Goldman's able to combine the perspectives of someone who provides frontline care to those in need, as well as being able to engage the community in revealing the culture of medicine. He's able to connect with the layperson and reveal how care providers think, how decisions are made, and how mistakes are made. On behalf of the Shaar Shalom Synagogue, I want to welcome you here tonight. This is the Saul Green Memorial Lecture. Dr. Green was a physician, surgeon, who worked for decades in this area, committed to his patients and practicing with integrity, and this tonight is part of his legacy. The lecture series, the mandate, is for ongoing learning and discussion of ethics, medicine, and humanitarianism. Thank you all for coming. I want to thank Dr. George Cooper and King's College for collaborating with us on this adventure. I want to thank Adrian Abbott, who's been instrumental in making this happen tonight. I want to thank Roselle Green and the Green family for helping with this tonight too. And last, I want to thank Dr. Brian Goldman for coming here tonight to speak with us tonight. Please help me welcome him.
I want to thank all of you for coming, but in particular, I want to thank the Green family for having me, and Shaar Shalom Synagogue, Seth, for a wonderful introduction, George Cooper, Dr. George Cooper, you had me at CBC board. When I give talks out of town, I like to call myself a fish out of water, and I love to be able to disarm my audiences by saying that, I feel a little uncomfortable, a little bit like a pork chop in a synagogue. The only problem with that is that I don't tonight, because I had such a wonderful meal at Roselle Green's, and I met the loveliest family, and I think the thing that made me feel at home was that it reminded me of the best of the dinners that we had on special occasions, and I won't forget that soon. It was the ease and the lighthearted banter that reminded me that family is what it's all about, and I know family was everything to Saul Green, and I'll have a few things to say about that at the end, because he's my muse. As I give tonight's presentation, I'm thinking, what would he think about all the things I'm going to talk about? Now, I have a few theories at the end because, as you know, if you listen to White Coat, Black Art, I'm not afraid to indulge in my theories, whether they're right or wrong. thank you for the empathy, for the empathetic welcome and making me feel not like a pork chop in a synagogue at all, but like a latke, or a piece of pickled herring, or gefilte fish in a. Those who don't know, we'll have a little glossary at the end of the. Anyway, I'm going to talk about a very serious subject, and it's certainly, one of the things that I unpack on White Coat, Black Art is the culture of modern medicine. I try to interpret what my colleagues, what me and my colleagues think and feel, our hopes and our dreams, and what makes us cranky in the morning. And I want to talk to you tonight about a serious problem that I think is becoming the big issue of the age. As medicine becomes more technologically excellent, I think we're missing something. We're missing a big thing, and I'm sure you all have stories, and perhaps you'll be able to share them with me afterwards. I am going to talk about what I think is a serious gap in empathy, and I don't think it's for anybody's fault. I think a lot of it has to do with the system, so I am going to talk about system factors, but I'm also going to talk about personal factors, who goes into medicine, how we train them, and what the history of medicine is, and show you where we're starting to fray at the edges, where it's becoming more and more apparent from the experiences of people who are in the system just how much we're missing through not being empathetic. And then finally, because I'm a solutions guy as well, a little bit about how to put it back. And for those of you who don't listen to the show, and this will be very interesting to see if we have the same kind of, I'll go back there. Good. So we'll use that control instead. White Coat, Black Art, I hope you all listen to it. It's a show about the culture of medicine. And the conceit of the show is that we pull back the curtain and reveal not what you think, but what we think. And when we give you a chance to react to that. And that's really the most important part of the show. And along the way, I'm not only going to give you a piece of my mind, I'm going to present to you some excerpts from the show so that you can experience some aspects of the empathy gap from the point of view of the people who've been on the show. And you're in for a bit of a treat. I'm writing a new book. It's called The Secret Language of Doctors. It's about medical slang, the history of medical slang, and what that slang reveals about the culture of modern medicine. And I'm going to present some excerpts of that as well. And then we'll get you to some solutions and then some time for questions. I would guess by a show of hands how many of you have had a momentary experience that you would describe as less than sympathetic. And the hands come up immediately. It's a joke. It's a cliche. In fact, it's a punchline, and I'm going to play you a couple of minutes of a brilliant British comedy called Little Britain, and this is a satire. It will be quite self-explanatory.
The British pride themselves on being the rudest, most unhelpful people in the world. Receptionist Carol Deere is working at this hospital in Pennsylvania.
Hello. This is my daughter. She's a big, brave girl, and she's going to have an operation today.
Name?
Tell the nice lady your name.
Danielle.
Danielle what?
Danielle Lloyd.
Age?
Nearly 6.
You're 5.
Yes.
We'll say 5 then. Address? Where do you live?
With Mommy and Daddy.
1772 Lincoln Road.
We got there. Putting your details in now.
Danielle's going to have her tonsils removed.
I've got her down for a double hip replacement.
Oh no, there must be some kind of mistake.
Computer says no.
Well, that must be some other Danielle Lloyd.
Computer says no. There's only one Danielle Lloyd on the system. Do you want the double hip replacement or not?
No, clearly she doesn't need it.
Well, she may do in the future.
You're laughing because it has a ring of truth. I mean, it's an exaggeration, but the surliness, the devotion to the computer process, And clearly not seeing that to a child being nearly 6 is very important, that she's not 5, she is nearly 6. Anyway, I guess it's hard to put that on a registration form. But so we're laughing about it, and clearly it indicates that there's a bit of a problem. I want to start with some definitions. And the definitions are very confusing. I used to think that sympathy came from the root sim, which meant the same, that somehow you were feeling the same feeling as the person that you're talking to. In fact, most definitions will call sympathy the capacity to show concern for another, while empathy is the capacity to recognize emotions being experienced by another, and that other can be real or a fictional character. You can empathize with a fictional character just as you can empathize with a real character. And when we say empathize, we mean demonstrating an empathic response, and it's partly cognitive, whereas sympathy tends to be more emotional. But if you think that those are official definitions, I can find you definitions that are totally different. But we are talking about some capacity to recognize the feelings in others. I was asked to provide a Jewish perspective tonight. This is the official Jewish perspective slide. According to the Torah, the scriptures, Moshe did not sit on a comfortable pillow but a rock. There was a battle going on with the Amalek, and this is a direct quote from the Torah. And Moshe wanted to feel the suffering of his people, and according to Moshe's paradigm, when someone else experiences pain, it is proper to do some action to feel some of the discomfort yourself. Well, you can understand right away that that's pretty difficult if you're a physician. Every time my patient has a colonoscopy, I'm not going to take the prep. As much as some patients might want me to. I want to talk about empathy in part from the standpoint of the stories that we tell. And you can learn something from those stories. I'm going to try to cut out just before this turns into something a bit blue, but have a listen to this animated, skit from an animated show that's very popular. Oh, my mistake. There we go. We'll get there in a minute.
Okay, heart sounds good. All right, Mr. Griffin, I'm just going to need you to drop your pants and we'll check your prostate.
What?
Drop your pants, turn around, and lean forward.
Okay. So how's this work? You just feel my pulse, so it... What the hell was that?
Mr. Griffin, that's a prostate exam.
Shut up! You had your finger in my ass!
Oh,
That's how a prostate exam
did
is
I not?
performed.
Oh my
Now,
goodness!
just
I
like
had the
that.
wrong finger on the wrong button. I'm sorry. I thought, whoa, that you didn't hear that. That didn't happen. Anyway, it begs the question: what kind of jokes do proctologists tell? And I actually had this one on the show. This is Dr. Mark Bernstein, who's a friend and colleague. He is a colorectal surgeon at St. Michael's Hospital in Toronto. And he told a funny story or two, and the clue is in the photograph.
There's an area that we refer to as social injuries of the rectum. And this includes foreign bodies and other traumas to the anorectal region. It's certainly not our business to be judgmental. It's our business to help patients. But you can imagine that sometimes we see some pretty unusual things in my specialty.
Like what?
Gee, are you interested in a list?
Oh, I think of one or two.
Well, zucchini and the cucumber are certainly on the hit list. We've seen everything from deodorant spray bottles to vases, similar objects. One of my favorite stories in this area is when a young man had to have a zucchini removed from the rectum. My senior resident, I was a junior resident at the time, and my senior resident and I left the operating room. I think we were not expecting to run into the young man's mother, who we ran into in the lounge outside the operating room, and she said to my senior, what was it? And my senior resident said it was a bowel obstruction. Not really prepared to give the whole story. I hadn't thought this through. Said it was a bowel obstruction, and she said, I knew it was something he ate.
Now you laughed. And I don't know how many of you are health professionals, but you laughed. And that's interesting because I managed to get this far into my presentation today at Dalhousie, and I kind of said, you're busted because I want to know why you laughed. And why do health professionals find this funny? We can ask you at the break why you find this funny, but health professionals find it funny in part because it permits them to express indirectly their own personal feelings about the patient's lifestyle, because this is entirely self-inflicted, and in some cases about what they have to do to fix the problem. And I can tell you that, the zucchini story is a funny story, but there's effort to remove it, might require surgery. And if I told you, and I don't want to make you too squeamish, that another story that Mark Bernstein told me that will be in my next book is about the individual who inserted a fluorescent light bulb that broke into many pieces. And this man had 8 or 9 operations to get him right. And in fact, those shards of glass were a danger to the operating team. So part of it is to vent. Another reason for the humor, telling these stories, is that the humor gives a polite means to share the story with others and to reinforce that mutual bond that we have. And I could ask you, maybe it doesn't bother you that they have the joke, as long as I don't hear it. If I never hear about it, maybe I can imagine they never say it. But some people might be offended by hearing that. You can't talk about stories like these without talking about what I call the secret language of doctors, or coded language. It has a formal, colloquially it's called medical slang. The more formal name is medical argot. I love that term. It comes from Les Miserables, the novel by Victor Hugo, and it was the language of the miserable, of the misery. And in fact, the first use of argot in that way was as a language used by robbers and thieves to talk shop in front of unsuspecting victims. And that actually is medical argot to a T. And it's no accident. It's not this kind of stuff, this kind of coded language, hieroglyphics and that sort of thing. No, it has terms that are like these. Gomers. Gomer is one of the first bits of medical argot to actually make it out into the general population. Gomer is an acronym for Get Out of My Emergency Room. And nobody uses it anymore. It was popularized in that book, The House of God. House of God by Stephen Bergman, used to call himself Samuel Shem because he was very concerned that people not know who he was. Now he's proud to call himself Stephen Bergman because in fact he's had many a medical resident and a student say that reading his book saved their lives. But he was the first person to popularize some of the slang. And nobody uses the phrase Gomer anymore, but they do use something called social medicine. Social medicine is the opposite of real medicine. And these are terms that are not in textbooks. They are part of the hidden curriculum. And if you want to understand what's in the hearts and minds of people like me, you must understand the hidden curriculum, and that's what I'm trying to introduce you to tonight. And the question is, what does that have to do with empathy, or what does it say about our empathy? And I hope to kind of illustrate that in the next few minutes. So LOLs and NAD is another one. An LOL is a little old lady in NAD, no apparent distress. Now that one tends to be used, it's not written down, but it's spoken. And we often use, so I was talking about real medicine, social medicine. Real medicine is when we put a chest tube in, when we take out an appendix, when we treat metabolic acidosis, or diabetic ketoacidosis, or an acute coronary syndrome with clot-busting drugs. That's real medicine. Social medicine is fixing up an elderly patient with a walker. That's not real medicine in the code. Okay? So what does that say about empathy? About empathy for the real condition of the patients that we're treating. 10 years ago, very interesting, a pediatric allergist in Great Britain named Adam Fox wrote this wonderful glossary. It was like hundreds and hundreds of terms that he'd collected, and then he promptly declared that medical slang was dead. Why? Because nobody writes it down in charts anymore. Nobody would write FLK in a chart, which stands for funny looking kid. And that was standard terminology not standard, it was a pretty widely used bit of slang to describe a child who was born who didn't look quite right. And, you know, it's kind of a objectifying, not very nice thing to say. And in fact, you'll never find it today in a chart, because if you did and something happened to that child and there was a lawsuit, that would be the end of the case right there. But the idea that the slang has disappeared is absurd. It just went underground. It became an oral language. And what I have discovered is quite a shocking array of terms that my colleagues use. You know, I haven't, you know, I have not, I didn't dream that it was as widespread and as deep. There are regional dialects. Some of them are witty. Percoceptopenia. That's somebody who's suffering from a lack of Percocet. So that's code for somebody who's what we would call a drug seeker, which is another bit of slang. Somebody who comes to the emergency department looking for narcotics. Some of these things I can't even say. I mean, there's a lot of florid blue language there. A lot of F-bombs, to be honest, in some of the slang. I'll give you one, but I won't say what it is. This is a legitimate term, the SFU 50. And it's used by anesthesiologists to talk about patients who are awake during an operation because they have medical issues for which a general anesthetic is a problem. So they're awake, they may be given some sedation, and by the by, as the procedure carries on, they start to become more animated, talkative. They begin to ask questions of the surgeon, questions of the anesthetist. I think you know where I'm going. Some of you do. And this is a play on a bit of technical language. There is something called the ED50. It's a pharmacological term for the effective dose in 50% of patients. So when a surgeon notices that the patient's awake, or the anesthetist notices and begins to hint at the SFU50, what is the SFU50 for this patient? What they're referring to is the amount of additional sedation that should be given to the patient to get them to... You got it. Right, and I'm not making any of this up. This is real language. In the United States, there is a particular issue these days with patients who are morbidly obese. So what you'll hear, you know, if a woman with a BMI north of 40 or 45 is about to have a cesarean section, the anesthetist will pipe in and say, "Is there a Beamer code in this?" Beamer for BMI, not BMW, BMI. And a Beamer code is a way of saying this patient is very large. I almost hesitate to say what harpooning the whale is all about, but you kind of know where I'm getting, you know, where I'm going with this. And this is a term used by anesthesiologists. With women, you know, less so men, because men don't get epidurals as often as women. Men do get epidurals if they're going to have a prostate operation. But if you've got a woman in active labor who needs an epidural for pain management, or wants an epidural for pain management, and happens to have a BMI north of 45 or 50, so we're talking about somebody who might weigh 400 pounds in pounds, they talk about using an extra long needle to be able to traverse the fat, get through the fat and into the epidural space. It's a TUI, it's a long TUI, that's named after somebody named Tui, but the nickname is a harpoon. And they refer to putting an epidural in that patient as harpooning the whale. And there's a serious side to this. The serious side is that it relates to the tremendous frustration, and that's why I started by saying this is an American phenomenon. There's a tremendous amount of frustration that surgeons feel in particular, anesthesiologists feel, and OBGYNs, obstetrician gynecologists feel when they have to operate on a patient who is very large, morbidly obese. Why? Because it's more difficult to operate on them, it's more difficult to anesthetize them, to protect their airway safely, they're more likely to have complications, they're more likely to have postoperative wound infections, and every once in a while, when the anesthetist has to lift the patient or assist in lifting the patient from the operating room table back to the gurney, to the bariatric gurney, so they won't break the gurney, that they can injure themselves. And I interviewed an anesthetist. One of his residents blew out a cervical disc doing just that and required spinal surgery to stabilize the spine. So part of it is born of real frustration. Let me give you some more slang, because that will take us to the other side of the gurney, as I like to say it on the show. You've probably heard of the codes. Everybody knows code blue, right? Cardiac arrest. Code blue used to be a neutral way of saying that somebody was in cardiac arrest so that everybody could go running and bystanders wouldn't be upset. Unfortunately, what happens is that when you put it into scripts like, on ER, private practice, Grey's Anatomy, House, etc., it ceases to be slang. It's the term. Everybody knows it's the term. And we have code red for violent patients. We have code orange. Of course, you know about code orange here. Code black might be for a disaster, a hospital disaster. Then again, there's something called code brown. And in one or two places on Earth, code brown is an environmental emergency, but everywhere else it's a bit of slang. It's a bit of slang for a poop emergency. And one of the things I want to be able to do by revealing the slang is to not only talk about it, it's not a glossary, but to tell stories about the slang and also tell you what the slang reveals about the culture of modern medicine. And it's very interesting and very telling that the people who have code brown stories overwhelmingly are not physicians. They are nurses, and in particular licensed practical nurses or registered practical nurses, because they're the ones who clean up the poop emergency. So that tells you something about who does what in the hospital and the hospital hierarchy. And paramedics do as well, by the way. If they have a code brown in the back of their vehicle, they have to clean it up. Nobody else to clean it up. And ask your nursing colleagues if they know what code brown is. They'll all tell you they do, and they all have a story. The important thing about that is that there's another side to the whole code brown story, and that is the patient's side. And I want to play for you a couple of minutes of this man, Shalom Goldman, who's the president of the Patients Association of Canada, founded in 2011 to put the patient perspective into every aspect of patient care, of health care. And they liaise with committees in hospital. Anytime they want to change the name badges, change the visiting hours, change whatever, they call on the Patients Association of Canada. So I want you to hear Code Brown from the standpoint of a patient.
When they prepared me for the CT scan, they told me that when I had the CT scan, there's a fluid that they give you, also that they inject in you, that might make me feel warm or hot. It might give me flushes. It might make me feel bad. It might make me ill later on. In some cases, it might make me very ill, and in certain cases, it might even kill me. That was the preparation. They didn't tell me that I might shit my pants. They said nothing about that. Yet when I went back to the emergency room from the CT scan, what happened was that I suddenly had this terrible urge to defecate, and it was all over the gurney, all over the floor, all over everything, and no one had prepared me for that. I mean, that was part of the story.
How did you feel?
First of all, it's very shocking to suddenly feel that you can't control yourself. I mean, that's a very shocking and scary thing to happen. You feel horrible, and you feel a little bit violated, and you feel a little bit ashamed, and you feel a little bit like you're imposing. I mean, it's all of those things. And then what happens is that after the shit has come out all over everything, they come and they clean it up as if it's nothing. And they say they very often don't tell people that when they give them a fluid enema of that kind that they will go to, and they don't tell us. They said it's not very nice of them not to tell us.
And you could argue that maybe making nothing of it is a way of being kind, but not talking about it, probably an issue, and assuming that it's not going to be an issue. And I will tell you that the older you are, and I'm talking about frail geriatric patients, the more we assume it's not an issue to the patient. And that's a huge mistake. So I do want to talk about the empathy gap. I think I've demonstrated that there may be an empathy problem here. So why? What's going on? I guess there are a lot of factors in the system. And the verbs that we use to talk about our workload in the emergency department, slammed, inundated, swamped. And the terminology, if you're eavesdropping, you would almost think that patients are the enemy. And in a sense, they are. It's not that they should be, but that's the way we treat them. And clearly, it's not. It's part of it is the volume, and I'm going to talk about the volume of business that we have these days. There are some other factors that contribute to that volume. Right now, about 5 million Canadians can't find a family doctor, and those who are still accepting patients may be screening. We call it cherry picking. So they're screening out high-maintenance patients, elderly patients, patients with multiple, we call them comorbidities. That's code for multiple illnesses, diabetes and kidney failure and heart disease and cholesterol and high blood pressure, etc. Also patients who with psychiatric issues and addiction, those who are homeless or indigent, and many of them do end up in the emergency department. And coming down the pike is the boomer tsunami. And the numbers are going to get bigger and bigger and bigger because seniors are the fastest growing population segment. Interestingly, you might think that the people who have a doctor are fortunate, and I guess they are, but even if you do, the care you receive is incredibly fragmented. You can pass from a doctor's office to a clinic, to the emergency department, to the inpatient ward, to a respite care, back home, to CCAC, and your list of medications doesn't follow you, and nobody knows what's going on. And this is a common theme throughout the system. In addition to that, even if you're lucky enough to have a family doctor, the chances are this person is either not skilled or, in many cases, not particularly interested in the plight of frail seniors. And you can talk about many of the reasons why. One of them is that there isn't a darn good fee code to handle all those comorbidities. So it's all the same intermediate assessment in our province, the province of Ontario where I work. And you're working towards a certain income, and you got to see a certain number of patients per hour, and whether it's 3 patients or 4 patients or 5 or some people 6 patients an hour, whatever it is, do the arithmetic. It's 15 minutes per, 20 minutes, 10 minutes per, 12 minutes per, not including the time it takes to write notes. And if any patient takes 5 minutes longer, then you better pray that the next one takes 5 minutes less. And no question, seniors take more time. They do. And also, the medicine that they have to offer is what I called, not real medicine, but social medicine. And I had the opportunity a few months back to interview 4 budding geriatrics residents. And the focus of the discussion, like we have 238 certified geriatricians in Canada, people like Samir Sinha in that photo, who's a bright light. We need about 500 more. And the trouble is trying to get people to want to become geriatricians. So here are 4 residents, and what they're going to talk about is the reaction of their colleagues when they announced they were going into geriatrics.
When I committed to geriatrics, the reaction that I got from my peers and from my staff and from even some of my mentors at my medical school was overwhelmingly negative. I was told that I was wasting my talents, that I was too smart to be doing something like that, and how could I pick a specialty where I wasn't actually helping people? This really bothered me. There is, I believe, a culture of ageism in medicine.
Amanda, you were nodding as he spoke.
I think we all share Nathan's frustrations in that geriatrics is perceived as a very negative subspecialty.
Rasa, do you agree with what you just heard?
So I think absolutely. I think my kind of stumbling upon geriatrics is very different than a lot of my colleagues. I ended up filling in a block with geriatrics just to get it done, and because I just had a daughter and I needed some time. So geriatrics is light and you don't do much, was the reputation. I came on and I loved it. And as soon as I started telling people I actually liked it, I found myself defending myself a lot. And we need to try to get rid of that stigma that's so closely attached, I think.
Jillian, do you agree?
For the most part, but I wouldn't necessarily say that it's not a respected career choice. I think just the reaction that I get is, well, I'm glad somebody wants to do it. Or, good for you, I would kill myself if I had to do that.
Wow, I'd kill myself if I had to be educated.
No, but like, I think I've actually probably heard that, or like I would gouge my eyeballs out if I had to spend an hour with a patient every time I saw them.
So what is the net effect? Certainly in the emergency department, which is the flashpoint, you have more people coming in who either don't have a family doctor or aren't having somebody spending the time with them that they need to take care of all those medical problems, and so it's fragmented care. So I don't know what their medications are, and it does take extra time, and as a result, they contribute, like all patients, to the general volume that we have, which leads to time pressure, distraction. We talk about running the gauntlet down the hall from here to maybe 20 feet away till I can get to my next task. I might be asked by 5 different people, students, nurses, patients, family members, about something, constantly disengaging me from that task until finally I get to the end of the hall and I've completely forgotten why I traversed the hallway. There's more opportunities for the system to fail us, more opportunities for that CT scan to not get done, or for the surgeon to not be available to see the patient, or for lab tests to get switched. So patient A and patient B get their opposite lab tests, and then we have to try to figure out what's going on there. More patients to complain, and very often rightfully so. Another species of patients that we see in the emergency department that are greeted with contempt, we call them frequent flyers. Not the same as Aeroplan frequent flyers. Air Canada frequent flyers are coveted. We want your business. Not so. I mean, this is an ironic twist on that. It refers to somebody who's really not wanted because they keep coming back for a whole bunch of reasons. Some of the slang terms that are used to describe them: crocs, cockroaches. The charitable term is superutilizers. It's just, and in fact, there's a remarkable guy, Jeff Brenner, in Camden, New Jersey, who's doing something about them by taking them away from the emergency department and giving them point of care treatment, and actually addressing those issues so that if they come to the emergency department, it's only because they really need to. And there's some more slang. Very interesting. A lot of the slang that Samuel Shem in the House of God debuted 40 years ago, it has fallen by the boards, but these are terms that have not fallen by the boards. Turfing, dumping, bouncing, blocking admissions. And they're talking about you, but they're really not, they're talking about you in the most objectifying way, like a piece of meat that I either block or I accept, but then find a quick way to send to another service. If I'm on the receiving end of this patient, then I've been dumped upon. And this terminology, these are verbs, not nouns, although sometimes they're called a turf, refers to what residents do to each other, what attending physicians do to each other. So for instance, in the emergency department, I see a patient who's got a little bit of chest pain, but has a whole bunch of medical problems, diabetes, high blood pressure, that are best managed by the internal medicine service, but they notice when I ask them to see the patient that one heart test is up. Can you please ask cardiology to see the patient? So I asked the cardiologist to see the patient, and the cardiologist says, but look at all these other medical problems. No, we think it'd be better if the general internist saw the patient. And it's going back and forth. Each one of them has tried to block the admission, and whoever ends up with the patient will feel as if they've been dumped upon. What's interesting is that we think this all happens behind closed doors, away from the patient, and it does. And so I've heard of patients who come, or residents who come to blows, fighting over who will be forced to take you. What's interesting is that there's at least one study to show that patients know. There was a study in which the researchers looked at turfing, patients who started on one service and were shunted to another admission service in the hospital, and they could tell who had been, and they asked the patients what they thought of their experience in hospital, and they were uniformly negative. They got it. They got that they were rejected. They got that somehow there was something not right about this. I felt like I'd been passed around like a football. This language has been studied by linguists, and Stern and Caldecott are experts in something called medical professionalism. Some of the underpinning here for the language: residents can feel angry and frustrated about receiving patients seemingly rejected by other doctors while feeling powerless to prevent the transfer of patients for whom they can offer neither effective treatment nor continuous relationship. Yeah, I had a slide. there's a good side to turfing. The good side is if you've got uneven numbers of patients from one admission ward to another and you redistribute them, that's good for patient safety, right? So if one team did 18 admissions one night, the next team does 4 the next night, doesn't it make sense to move some of them over so that you can share the load? That's fine. What isn't fine is what happens the next morning. If turfing or dumping or blocking are congratulated in a celebratory way, like an Olympic sport. The resident comes on and says, I blocked 4 admits last night, and gets high fives. So it turns into a bit of a competitive sport. That is considered unprofessional, and that's really objectifying patients. There are certainly attitudes towards seniors in hospital. Today's hospitalized patients are sicker, and they're more stressful to manage. A significant amount of that stress is reflected in attitudes towards hospitalized seniors. And we're dealing with the fact that very frail senior patients might want to talk, might be a little slower giving a history, a little slower getting to the bathroom, and some of that frustration, unfortunately, is vented out on the patients. And I'm not just pointing fingers. There's another bit of slang that we call the veterinary workup. And I say this with apologies if there's anybody in this audience who's a veterinarian. It's slang, and it's an insult at me, because no veterinarian would ever treat an animal the way I'm talking about here. What I'm talking about is walking into an emergency cubicle, asking 1 or 2 questions, ascertaining very quickly that the patient doesn't know who they are or can give a history, and then asking them, do you know who you are, where you are, and what day it is, and then very quickly proceeding to a physical examination without introducing myself to the patient. And I can tell you that we're very self-conscious about it. Now that I've got a mother with advanced Alzheimer's disease who happens to be in hospital right now, I can tell you, I can see who feels comfortable introducing themselves to my mom and who doesn't, who acts as if she's not there, which is a big problem that I'll close with at the end. One of the things that I said I would talk about for just a moment, do attitudes like that mean we're ageist? Probably. Certainly from the standpoint of this man, David Goldman, his father died of a stroke that went undetected and untreated at a hospital in Ottawa, and he actually started a public awareness campaign about ageism in the medical system. What bothered him was that the medical staff that admitted his father suspected he might have a stroke, but told the family that he thought it was pneumonia, and did not order a CT scan that might have resulted in quicker action and might have saved his life later on. And it was only later, when Goldman looked at the hospital chart after his father had passed away, that he saw what he called the smoking gun. That in fact, even though the doctors had said they didn't think there was a stroke, in fact, early on they suspected a stroke but did nothing about it. We could have arguments back and forth. A clinician by the name of David Alter did a study looking for gender bias in cardiac care, heart care. What he found was age bias. He thinks a lot of that age bias is in fact age appropriate. And I can tell you, when my dad had his heart attack and he could not get an angioplasty because he was considered too high risk for that, it was considered too high risk a procedure, he was given a 5-minute consult for a possible coronary bypass. He was 89 years old, and honestly I was secretly glad that they did a 10-minute consult and said, no, we're not operating. Because my fear was that he would lose, if he lost 10% of his brain function, his cognition, that would be enough to land him in a nursing home, and because that can happen with a coronary bypass. On the other hand, there are clinicians, and Janice Lassard, geriatrician in Toronto, is one of them, who believes that ageism is rampant, and I want you to hear a moment of her talking about that.
Oh, I can give you some quotes from my colleagues. People who reside in nursing homes should not be allowed to come to any emergency department.
You've heard that?
Oh, yes. If there's a 80-year-old and a 50-year-old in my emergency department with a heart attack, there's not enough of me to go around. I'll look after the 50-year-old. These are standard.
I've certainly heard colleagues talk about a senior patient blocking a bed in the acute care hospital.
And that's true, but look why it's true. You can't get them out of the hospital unless you fix them, or they die. So the answer is fix them. Unfortunately, doctors don't know how because they have no training. They assume they can't, and so what they want are more nursing home beds to offload them. That's not the answer. The answer is fix them. They're easy to fix.
We can't, with the skill and the training, and that's why we need more geriatricians. We can't go much further in this discussion without talking about the reality with the boomer tsunami, with an aging population, that eventually everybody will die. And we do have a death-denying culture. And the result of that, and we don't celebrate death the same way that we celebrate life. I mean, nobody should be happy about a death, but summarizing a life and celebrating somebody's life, Sharon Carstairs said that when she wrote a groundbreaking report into the lack of palliative care in Canada, and I think there's some sense to that. There's no question that we spend, in that death-denying culture, we spend more money in the last 2 years of our lives on health care than we spend in all the other years combined. I can tell you at the same time that as that is happening, there is a bubbling undercurrent of frustration amongst medical colleagues. They believe that a lot of that money is being wasted, and I suspect that they believe that any acute care on my mother is a waste right now. She's in hospital right now being rehydrated, and I admit that gives me some misgivings myself. But the point I'm trying to make is that a lot of my colleagues have very strong opinions about this. And the idea, if you don't know that they think that the treatment is futile, and they're frustrated when they feel as if they have to offer it, then you're missing a significant cause of lack of empathy. And you may have heard about this case of this man, Hassan Rasul, who went into hospital to have brain surgery to remove a tumor and ended up with a post-op infection and is now either in a vegetative state or he isn't. And that's the discussion at the Supreme Court of Canada. His doctors applied to the courts to have him taken off life support. And the terminology is really, really telling. Is it life support? Is it death delaying? Is it life prolonging? And the language you use really determines how you feel about that. His family believes that he is in fact sentient, cognizant, and in fact you may have seen in the news a technique that was used, a kind of a groundbreaking technique that may have indicated that he is more conscious and aware than his doctors have thought. Since there has been another study that has another look at the same data suggested that was just signal noise and he's no more awake than anybody in a vegetative state. Stay tuned. But this is a major debate and a major source of conflict. Here's another one that's part of the system that I want to talk to you about in just a moment, and then we'll come up with some solutions. Again, Nathan Stahl. There's a little ritual that's part of death in hospital, and it's called getting the DNR. DNR stands for do not resuscitate, and I put these other things up, these other examples up to show you that not everybody sees DNR as do not resuscitate, just that you're aware of that. What we're doing these days with getting the DNR sounds like an achievement, something that it's a rite of passage that a senior resident will often task a senior medical student or a an intern, a first-year resident. It's your job to get the DNR, which is a piece of paper that says that, if my loved one, if my family member's heart should stop, no CPR. If they should stop breathing, no intubation, no admission to the intensive care unit. And often what happens is that the family may have signed advance directives, but very often what happens is that a hypothetical risk of death or imminence of death has become very real. And this is the moment when your loved one's admitted to hospital and there's a conversation, could be in a corridor, could be at the bedside. Your loved one isn't doing well, and I have to have this. I'm a little uncomfortable. I have to have this conversation with you. We hope for the best, but if your loved one should take a turn for the worst. So now they're actually hearing could take a turn for the worst. This could be happening, and sometimes we're more forceful. Followed, so no opportunity to digest that information, and then followed very quickly by if your loved one's heart should stop, what do you want us to do? Here are the options. In fact, it's become very menu-driven. because you can't say anymore no heroic measures, because what's heroic measures? So now it's actually, it actually gets parsed down to IV, what kind of IV, endotracheal tube, BiPAP, defibrillation, CPR, these drugs to treat an infection, transferred to the intensive care unit or not. And there's a lot of choices that are being offered at a moment when all you're hearing is good chance not going to make it. And I want you to hear Nathan Stahl express his misgivings about this approach.
End-of-life care, I think we do an abysmal job of this in Canada. So many patients come in without advance directives. But now our response to that has created this extremely awkward scenario where you come with this sheet and it's like a menu. It's like you're going out for dinner and you're asking these patients and these families, do you want full care or not care? But then, do you want imaging? Do you want antibiotics? Do you want blood work? Do you want a tube? And to go through this whole thing often with a cognitively not completely intact person is so awkward. I actually hate it now. And this is someone who believes that this is such an important thing to do, but I think it's just the most awkward conversation. Usually they look at you and say, well, I don't know. And that's often an impossible question to answer because you're talking about a hypothetical scenario anyways. And then each time they come to the hospital, you have to do the whole same thing over again. I really hate the menu option of how do you want to die.
Part of what he's feeling is something called compassion fatigue. For a family, this is the worst that could happen, and this is a singular event in your life. For the person who's getting the DNR, this might be the 100th time they've done it. They've gone through this discussion, and they're getting good at it. They're getting so good at it, they've become emotionally distant. And there is something called compassion fatigue, also known as secondary traumatic stress disorder. This is a term that talks about a gradual lessening of compassion over time. And it often occurs in paramedics, in nurses, people who have witnessed severe traumas, patients who've had really catastrophic injuries, particularly children, but not restricted to children. And it's considered a risk factor for burnout. And burnout is a stress syndrome that's characterized by three things: emotional exhaustion, decreased satisfaction at work, and distancing from coworkers. And I have to tell you that in spite of what you hear about great satisfaction, bubbling under the surface is this quiet despair. That in some surveys, burnout rates can be as high as 50%, and they are astonishingly high in trainees, in residents, and in students, and it really begs the question, what are we putting them through? I want to talk about the route, like I was asked on Main Street, how did we get from there to here? What's happened? What's the history of this? And I know I'm almost running out of time, but I got to get to this. Because where did this all begin? Well, it all began in the 19th century with a very influential Canadian physician named Sir William Osler. And when he worked at McGill, he was in Europe, he went back to McGill, he studied at McGill, went to Europe, went back to McGill, went to Philadelphia, and his farewell address before he headed to Johns Hopkins and helped found their School of Medicine and their Johns Hopkins Hospital, one of the first 4 professors, professor of medicine, surgery, gynecology, etc. He wrote an essay called Equanimitas, which is the Latin for equanimity. And the word he used was imperturbability, and this is a direct steal from the essay. Imperturbability means coolness and presence of mind under all circumstances, calmness in storm, clearness of judgment in moments of grave peril, immobility, impassiveness, and it goes on. And he says we should have phlegm, which is not that's phlegm and bile and all the other humors that he was being poetic and metaphorical at that time. I have a lot of phlegm, but not of this kind. To put Sir William Osler's admonition into modern parlance, never let him see you sweat. That's basically what it is. No matter how horrible, horrific it is, never let him see you sweat. And in fact, Dr. Renee Fox, who's a medical sociologist, she did some groundbreaking medical sociological studies of first-year students, second-year students, residents, and a remarkable group of physicians in Boston. She did these in the 1950s, and she wrote an essay which was unpublished for many years until 1988 when it was published, 1979, sorry, and then the second edition in 1990. And she described the ritual of second-year med students at Cornell University Medical Center Columbia University, attending their first autopsy. And she described it as a landmark milestone experience, an emotionally important experience of the hurdles you have to get over along the way to becoming a doctor. And she was one of the first to use the phrase detached concern. So you're supposed to be detached, as Osler suggested, but concerned at the same time. And it's evolved into trying to find the balance between not falling to pieces over everything that you see, and you see a lot, and at the same time offering an empathetic response. And it's darn difficult to do. How do you find that balance? How do you find that balance? You know, when you see, when you're a paramedic who has scooped up a subway jumper, and which is a horrific kind of emergency to attend. And I saw the aftermath. I saw a woman who had been decapitated and was brought to the emergency department and arranged to look like a body. And it was only as I was there to pronounce the patient. They don't have to do that anymore. Step by step by step, I knew there was something wrong. I saw her eyes were open and looking up, and then I realized as I approached with my stethoscope that the torso was pointed down. And I saw a paramedic snickering in the background, like they got me. And it's only more recently that I've begun to wonder, what were they thinking? What was on their minds? I'm not worried about me, I'm worried about them. And I would put it to you that Sir William Osler didn't see this. He saw people dying of consumption and infections, and yes, he saw kids dying of diphtheria, but it was expected. Death was part of the program at that time, and it just isn't these days. We live in a risk-averse culture where we can do more, we can harm patients more, and they're going to sue us. People are watching us, and they're going to notice if we screw up. And what does that result in? It results in us being self-absorbed. Have you had that experience where you think that it's all about us and it's not about you? That whole business of clerking in the girl who's nearly 6 was all about getting the paperwork right and was not about attending to the comfort of the little girl or her mother, for that matter. And that's often what it's about. You know, when somebody expresses a negative emotion to us, often our first thought is to flinch. Oh, we're going to get sued, we're going to get complained about, what have I done now? I'm working as hard as I can. And you can begin to understand why they might feel that way. Almost done. Can't talk about the death of empathy without talking about the birth of technology like this. And there's a lot of talk these days that we're spending our time buried nose into the monitor and not looking at the patient. When I say that, I mean the computer monitor or our Palm Pilots or our iPads, because they're giving us so much information and they're telling us so little about the patient at the same time. They're essential and useless at the same time. And no time for this, but sometimes when your best efforts aren't appreciated. I had a whole discussion with these two wonderful family doctors, John Axler and Donna Henriksen. I started the conversation by saying that I spent a lot of time with a patient in the emergency department one night. Every time I walked by, he had a question. I stopped and answered each one nicely. And he went home eventually. A couple of weeks later, he calls me to complain about the nurse who was looking after him. And I had the misfortune of asking, so how was I? And I'll never forget when he said to me, you were nothing special. And all of us have a story of working double time to really, really try to help somebody and having them kind of throw it back in our face like it wasn't. Donna Henriksen told a wonderful story of detecting a heart attack and heart failure and saving a woman's life. And then one time, maybe a year later, the one time that she was very busy, she sent the patient down to the hospital because she was having a recurrence of her heart failure, and they quit her practice. And the husband said, well, now we know we can't count on you anymore, when she was expediting and trying to do the best thing. I could spend an hour talking about this. How empathetic we are with our patients is really marked by how empathetic we are to each other, and we suck at that. If I make a mistake, there isn't anybody who's going to comfort. Well, maybe one or two people might comfort me, but most of us are just going to be exasperated. We don't like to debrief about what happened. we have this vicarious shame if somebody makes a mistake. If I thought somebody took the wrong leg off in a hospital, I and most of my colleagues would have trouble making eye contact. I did say that there's reason for hope. First thing is that newborns have the ability to empathize. Newborns cry when other newborns cry. Newborns display signs of distress when their parents are in distress. Not other people's parents, their parents. So they're hardwired to empathize. Very recent study by researchers at Harvard Medical School. 18 physicians, 2 standardized patients. In the first part, they were all hooked up to a functional MRI so you could see like a moving picture of their brain function. In the first part of the experiment, physicians who were exposed to a particular model of pain, heat-generated pain, and pain relief. With the pain relief, a part of their brain called the ventrolateral prefrontal cortex lit up. Part 2 of the experiment was for the physicians to be instructed to press a button to knowingly provide pain relief to a patient or no pain relief, a sham. And what's interesting is that the physicians, when they knew they were giving the sham, the fake treatment, that part of the brain did not light up, but when they knew they were giving the pain management to their patient, the very same part of the brain lit up as when they were getting themselves pain management. Proof that physicians can feel their patient's pain. So, how do we fix this? Well, I talked a lot about the system. The first thing we have to do is fix the system. And one way to fix the system, I guess, first of all, we have to get rid of every nuisance job that keeps us from patients. We have to make patients a priority. And the way to do that is to just analyze what we do, lean, whatever, Toyota, whatever. Just look and just count the number of hours you're doing things that are stupid, that could be done by somebody else or could be automated to be done better. And I'm a big proponent of electronic health records and reconciling lists of medications and doing that stuff. And at the transition points, having somebody help us with the information from transition from nursing home to hospital or from hospital to home care, from home care to clinic, et cetera, so that we can spend more time with the patient. Anytime we can do something like that, it has to be a net benefit to the patient. Second thing we can do, embrace the role of other professionals, whether they're nurse practitioners or physician assistants, extended care paramedics, which you have here in Halifax, and put us all on a team. And when I say team, I don't mean physician is team captain. I mean a team where everybody's equal and everybody can make comments because everybody's opinion's valid. To get rid of the kind of hierarchical, I'm the boss because I'm the smartest person in the room culture of medicine, it's going to require a lot of effort, but that's what we need. So that if I'm feeling down about a patient, I can talk about them. If I'm sick, I can stay home because there's a nurse practitioner who knows the patient, and so I don't have to feel as if I have to stay even when I'm sick. And there's so many other ramifications of that. We've got to move some of the care out of the emergency department, and one way is house calls. If all else fails, how about loving the patients you've got? Take a look at this.
We became convinced at Holy Cross this wasn't the best way to deliver care in a big emergency room with all of the noise and all of the bustle going on. So we've worked together with the Erickson School to design a seniors emergency room, one just for people who need special attention and special care. So we've tried to look at everything from the environment, making it quieter, making it more soothing, to things as simple as mattresses and televisions and the like, so that when seniors are here, they're in a more relaxed state. Care of seniors in EDs is not our shining moment in healthcare. And my hope is that we can make a small contribution toward making it better.
That enough? Is that a good idea? Now, I can tell you in the culture of medicine, immediately as soon as this started, this idea came out, experts, pointy-headed experts started to say there's no evidence that it provides any better care. It's a conceptual, it's an idea. Work with it. It's not that if the first go around is pretty walls and not better care, that we should junk the idea. And sometimes people are biased and they're looking for a reason why something isn't going to work. And then as soon as they find the first evidence that it doesn't work, well, that's it. Glad we tried that. So sad, too bad. Those are system fixes, personal fixes. All of us who are physicians, nurses, paramedics, healthcare providers have to learn the empathic response. The empathic response is sitting with the patient at their level, like don't stand over them, sit, act like you've got all the time in the world. And when a patient or a family member expresses a feeling in their words or gestures, delivering an empathic response means that you are acknowledging their feelings. And there are many reasons why we don't do it. A fear that a 5 or 8 minute visit in the emergency department or a clinic will spiral into 40 minutes. Fear of raising expectations that can't be met. Mistaking empathy for sympathy, that how can I be empathic if I don't feel the way they do? That's that old definition. Empathy is seen as a personality trait, so I'm not empathic. I wasn't born that way. Or it's been drummed out of me, I can't learn it. And then finally that you can't learn it. And it turns out that the empathic response is as easy to learn as putting in stitches. You just have to learn it. You have to have somebody to teach you, and I was fortunate to have this man, who I miss very dearly, the late Robert Buckman, a friend, a mentor, a colleague, who has written many, many books on medical communication, on how to talk to patients, and he taught me how to break bad news in the emergency department, and I want to just spend a minute hearing his voice, because I love to hear his voice. We call this show White Coat, Black Art. So what's the black art to breaking bad news?
The black art is actually very simple, and it's much more simple than you thought it was. Rule number 1, before you tell, ask. That before you go blundering and saying, they found a cancer in that lump in your abdomen, or whatever it is, you find out what the patient thought about the situation first, and then respond to every emotion that the patient expresses. So if the patient says, I can't believe it, you don't say, you've got to believe it, it's true. That would be wrong. You'd say, difficult to believe, isn't it? You acknowledge the fact that it is difficult for them to believe it. If the patient says, no, that can't be, instead of saying, oh, yes, it can, you would say, this is a terrible shock to you, isn't it? Or this is awful, or this is overwhelming. The actual words don't matter. The action of the empathic response is to acknowledge the emotion in what the other person says, and that's what you do.
Just let me close by saying that, it's often said that physicians become good physicians and see things from the patient's point of view by being patients themselves. And I think that's also true for the vicarious experience of being a son, a daughter, a partner. And this little clock reminds me that every 5 minutes somebody in this country is diagnosed with dementia. And about 18 years ago, it was my mom's turn. And I would wish I were with her tonight. She taught me a lot. I became a writer, and I hand wrote my first article in the Goldman Mail, and she typed it. And so she's a part of everything I do. And my mom, I've seen great care. I've seen a lot of loving care. I've also seen some of the less proud moments of medicine. Right now, as we speak, the last couple of days, one acute care nurse after another. My mom's in hospital with dehydration and constipation. Yes, you can die of constipation. She almost died of constipation. If you're not checking, you can. One acute care nurse after another said you can't feed her because she won't eat, until I came in and my sister Joanne came in, and we showed them all you have to do is engage her. All you have to do is talk to her, damp cloth in her face, talk to her. I like to bring music. And iPhones are wonderful. My mom loves show music. Let's see if I can actually find, well, not that. Too depressing. Well, there are some really depressing albums that you can play. And, but, this one really gets her. Let's see if I can actually find it. Here we are.
Edelweiss,
We used to play The Sound of Music, the original, not the movie version, the Mary Martin version. This is Theodore Bickel. She used to love Theo Bickel, and her eyes will open up, and she'll have that flashbulb moment where she's back. And I connect with her through music. And my point is that if you make an effort to connect, you can. And if we, as physicians and healthcare providers, make that effort to connect, we can. And we can find that not only is it good for our patients, but it's actually good for us. There's actually studies to show that being more empathetic is good for the health of healthcare providers too. And I wanted to close with one thing, and I said I was going to say something about Saul Green, and I want to. What would he say if he heard this talk? Would he be disappointed in us? Would he say we could do better? And you know what? I don't think he would. I think that he was a practical guy. One story I heard from Howard Conter, who isn't here tonight because he's at the Tema Conter in Toronto tonight. He said to me that Saul and his buddies used to like to have competitive sales and would like to buy things that were more on discount. And he was a practical guy. Saul might be the kind of guy who would be told by his buds that at Simpsons the golf pants are 50% off. And his response would be, and if I don't take the pants, I get the other 50%. So what would he say? I think he was pretty empathetic. And he showed his empathy in those pre-Medicare days when he provided care regardless of ability to pay. And I'm not sure a lot of my colleagues would do that today. But I think he would, if I could cop the phrase, from Forrest Gump, that empathy is as empathy does. And as a doer of empathy, he was unparalleled. So I just want to say thank you so much for giving me an opportunity to give this talk tonight. I know I've run a little over, but when we have a chance to settle, I'll be happy to answer your questions. Thank you.
Great. Love it. Thank you. Well, I have to say, Brian, that I never imagined in my wildest dreams that a talk about empathy would hinge on zucchinis, but here we are. And what a demonstration you've given us this evening. What a wonderful demonstration about how to take a really important message and drive it home with humor and with poignancy. You've done us a wonderful job. You mentioned Sharon Carstairs, born and raised not 5 blocks from the greenhouse here in Halifax, a Canadian expert and a wonderful person, expert on palliative care. I can give you an example of one of those medical acronyms. A friend of mine had a brain tumor, and he went to the hospital, and it was the subject of a CAT scan, or perhaps an MRI, I can't remember exactly. But it turned out that the brain tumor was completely benign. In fact, it was a meningioma which existed not inside the brain lining, but outside the brain lining, between the brain lining and the skull. And the doctor in question said, you'll die of old age before that'll ever get you. And in fact, you have been subjected to vomit. And the patient said, what's vomit? Victim of medical imaging technology. So there you go. The people in this audience tonight, Brian, showed no detached concern. We were completely engaged the whole way through, completely captivated, and I want to thank you very much indeed on behalf of all of us here tonight for so eloquently bringing to life the very thing which Saul Green lived for, which was empathy in the exercise of his profession throughout his career, his distinguished career. So that's it for me. I'm going to now turn the meeting over to Dr. Kim Kierans. Kim is the academic vice president of the University of King's College and a journalist and the former director of the School of Journalism, and she will now, former CBC journalist, I might say, and she will now have questions and answers from the audience. Thank you.
Thank you all for being here, for your warm response to Dr. Goldman, and we are running short of time, so I'll only allowed to take 3 questions. So, I see a hand there. Please stand up. Very loud, please.
Hi, Dr. Goldman. Thank you very much for your talk. I saw you actually a year ago in Edmonton, and you were great there too. So one of the things that the University of Alberta has for the medical students is an event every year called Med Night. It's actually 3 or 4 nights. I don't know if they have a similar program here at Dalhousie. But the medical students use it essentially as a way for them to vent the frustrations with their training in a humorous way. So much so to the point that every year that I've gone, they kind of open it with a caveat for the audience saying, if you're easily offended, please leave now. Because some of the stuff that we talk about is just, it's very, it can be very dark or disturbing or glib or flippant for some people. So we talked a little bit about how we've seen the students and the professionals within the medical community that have this terminology. I know that it can be blamed on the system, but what are some ways that, like, where's the line, and how are some ways that we can better address these remarks for patient care?
Well, that's. Let me start with the midnight or daffodil or tachycardia. They all have different names. First of all, I think that everybody's got a right to vent, and people do have frustrations, and I don't think anybody should condemn people for wanting to vent, and if it's framed in that way, and it's kind of a comedy review, some people may not find it funny. Some people don't find comedy in general funny. I don't have a problem with that. I'm also going to say something a bit counterintuitive. I don't have a problem with the slang. I don't think the slang's, not just because I'm writing a book about it, but because the more you try to mash it down, the more you're just going to make it more hidden. People will use slang. The slang isn't the problem. It's a symptom. It's a symptom in some cases of frustration, and I've given you lots of reasons in the system why there may be frustrations. I didn't talk at length about the difficult hours that residents have, for instance. They're more likely to use slang. And it would be far better to know about the slang and to monitor it, not to say got you, but to say, boy, we're hearing more slang these days. Is there a problem with the system right now? So that's how I would use it. And I would be grateful for hearing it. And I don't. And I mean, there's something called the hidden curriculum, which is the gap between what professors teach and what students learn. And it's not just the hidden curriculum of medicine; it's hidden curriculum everywhere. But the whole idea is that you really want to capture what people feel they need to learn to get by in their jobs. To learn what it's like, am I too pushy? Am I too aggressive? Do my colleagues like me? Am I getting along with them? Am I functioning in the system? So rather than saying we should try to eradicate it, use it as a barometer. And I would want to know where it's happening, and invite students in to talk about it and reflect on it, or residents to reflect on it, and use it as a symptom instead.
Question maybe from this area. Is there someone who has a question?
Hi. Thanks for the talk. I'm really interested in the issue of ageism in both the healthcare and the medical industry. It seems like a really large issue. So they are finding, and I've looked at research too, that it seems to be the same, if not more, in the general society, the ageist attitudes. How can you empathize when people may be holding that prejudice, at least in that healthcare industry, with a portion of the population that will be accessing the services? How do you work around, how do you deal with empathy when you may hold those prejudices, ageist attitudes?
Well, and that's a really good question. There is the prejudice, and there are the real issues, that the real sources of frustration. Ageism, and I think that expressing frustration about the fact that I don't have proper time, I don't have enough time to look after the needs of this patient who's got on 12 medications, unless of course I have a team. If I have a team with a case manager and maybe a geriatrician who can make periodic visits and a pharmacist who can reconcile do medication reconciliation. If I've got all that stuff, then the issues that result in, and if the issues that resulted in those kind of catty remarks, those cutting remarks, are gone, anything that's left over after that would probably be prejudicial. I would maintain that a lot of those negative remarks that are a reflection of frustration would disappear if the frustrations disappeared. Okay. Full-on ageism is saying that a person of a particular age isn't worth saving because of their age, or saying that they're not fit for this operation when in fact they may be fit for this operation. And if you look at the medical literature, operations including heart transplants, lung transplants, they're not likely to be done, but they can be done. Certainly bypasses can be done in nonagenarians and even centenarians. And we're learning as people get older, as our population ages, that it's possible to provide treatment that would have been considered unheard of decades ago. So anybody who after that still believes that an older person isn't deserving of an operation or can't go through the operation, I don't even have to think about them, that's ageism. Assuming, for instance, that somebody who's 87 years old isn't humiliated by an episode of incontinence is ageist. And unfortunately, there is all too much of that out there in the system. There's a lot of good people in the system as well, but the culture tolerates it a little too much, the culture of modern medicine.
I have one more question, Steph. Do you want to go to the mic? This is a student here at the school, fourth-year student.
Hello. Thank you for coming in and giving this lecture. I wrote it down because I get nervous. So mental health and mental illness are being talked about a lot these days. And tonight you talked a lot about seniors and ageism. But where do you think those with mental health problems come into this question? And do you think that medical practitioners are dealing with those with mental health problems with enough empathy?
That's a really good question. And I was kind of steered towards focusing on seniors. But what I said, I touched on frequent flyers, who are the people who come back again and again to the hospital, get readmitted back again and again to the emergency department. If you see them as a problem because they keep coming back, like you again, then you're missing the point. The point is that they're coming to the emergency department because they have real needs that aren't being well looked after elsewhere. If you can find a better place, design a better place for them to be well looked after elsewhere, then they won't come to the emergency department because they actually will get better care elsewhere. And that's what Jeff Brenner is doing in Camden, New Jersey, where he found the apartment building that consumes humongous resources, $175 million a year in healthcare resources from the people who live in that one apartment building. So what he did was he brought healthcare to the apartment building. And he was able to do it in a low-cost way and improve their health, improve their compliance by making it easy for them to receive medical care. Now, back to your point. That's just a lot of the people who would go again and again to the emergency department are indigent, are homeless, and many of them have mental health problems. And I would suggest that a lot of the problem dealing with people with mental health problems is that, or the challenge is that we don't have enough people who are skilled in managing chronic emotional and mental illness. And I would say, I can't snap my fingers and say we can solve the problem today. We probably have to, I can tell you when it comes to geriatrics, I could spend an hour talking about the fact that a frail senior is not an old adult. They have a different physiology, and we know a lot about their physiology. We need to know a lot more about what makes people with mental health problems tick, so that we can do more than simply manage their medications and get frustrated by their behavior. Because I think there's a lot of that going on. All you have to do is turn on the television and watch, what happened with Ashley Smith in prison. And that's what happens. A lot of people with mental health problems end up in prison because our mental health resources are woefully lacking in this country. And they have become default dumping grounds for people with mental health problems. So forgive me for not talking about it at length. In the next hour, if you have me come back, I'll be happy to talk about it. You're absolutely right, though.
On that note, I would like to thank Dr. Goldman, thank all of you, thank Roselle and the Green family for this wonderful evening. And Dr. Goldman will be signing books in the back outside after. And thank you all for coming tonight. Dr. Goldman.